de alto volumen. Han estado en muchas charlas y seguro que saben ya que la hemodiafiltración de alto volumen es una terapia que aúna innovación científica, mejores resultados clínicos para los pacientes y mejor calidad de vida para los pacientes. A nosotros nos gustaría que hoy aumente sus conocimientos, actualicen sus conocimientos, intercambiemos perspectivas para aplicar la mejor terapia a cada uno de sus pacientes. Todos los que estamos acá tenemos un deseo común, o deberíamos tenerlo, que es ofrecer la mejor medicina posible para nuestros pacientes. Y la hemodiafiltración de alto volumen ayuda con este propósito. Empezó hace 40 años, fundamentalmente en Europa, pero Latinoamérica no se ha quedado atrás. Hace 20 años, porque fue en 2005, la primera máquina de hemodiafiltración, ¿saben dónde llegó? ¿A qué país? Por acá hay mexicanos. Pues llegó a México. Pero rápidamente los argentinos se pusieron las pilas y dijeron nosotros también. Los colombianos, Brasil ahora mismo, si tenemos brasileños en la sala, es el país de Latinoamérica con más pacientes. Tienen 10.000 pacientes haciendo hemodiafiltración de alto volumen. Después Ecuador, luego Uruguay, Chile me lo he dejado, que también empezó por allí, la doctora Herrera. Chile, Uruguay, Perú, Bolivia, Guatemala. Quiero decir que se puede hacer hemodiafiltración de alto volumen en Latinoamérica. Todos estos países han demostrado que se puede tener calidad de líquido de diálisis para hacer hemodiafiltración, que se pueden tener buenos accesos vasculares con buenos flujos sanguíneos para cualquier terapia extracorpórea y también para hemodiafiltración, que se puede dializar 4 horas, se puede hacer. Todos estos países han demostrado que se puede invertir, que es costo efectiva, que si queremos, podemos. Y hay un factor que tiene Latinoamérica que no tiene Europa. Es que son ustedes muy talentosos y súper creativos ante la adversidad y son capaces de implementar hasta lo no implementable. Entonces, han hecho ya historia muchos de ustedes, pero queremos que esa historia se multiplique y se amplíe a muchísimos más pacientes, porque veíamos que estos pacientes ahora mismo haciendo hemodiafiltración en Latinoamérica deben ser como el 7%, un porcentaje muy chiquitito para el impacto positivo que tiene la terapia en los pacientes. Entonces, para seguir aumentando esa historia, tenemos la suerte, todos los que estamos aquí, de contar hoy. Yo siempre digo, todos los que me han escuchado, que tenemos hoy la suerte de tener al profesor Bernard Canaud. Él fue un visionario, es un pionero. Ha desarrollado 40 años las primeras publicaciones de hemodiafiltración de alto volumen. ¿Saben quién es el autor principal? El doctor Bernard Canaud. Una de las últimas revisiones narrativas muy bien desarrolladas de hemodiafiltración, el doctor Canaud. Son 40 años de evolución de la terapia, 150 publicaciones. Fue pionero. Clínico, científico, investigador, académico. Para mí es un orgullo y es un honor poder presentarle. Así que muchísimas gracias, doctor Canaud, por ser tan generoso con nosotros y compartir toda esta experiencia, estos 40 años de desarrollo de la terapia. Perdónenme que les voy a poner una cosita antes, doc. Queremos que este sea un espacio con innovación, participación. Todos conocen al doctor Canaud. Entonces, como queremos que todas puedan participar y preguntar, hasta los más tímidos, que yo sé que hay tímidos en la sala, si no quieren luego hacer las preguntas por micro, las pueden mandar a este QR, que yo las recibiré e intentaré hacerlas, o por lo menos aunarlas, o si no, luego las respondemos como podamos. Muchísimas gracias, doctor Canaud, muchísimas gracias a toda la organización, muchísimas gracias a ustedes por estar aquí para impactar cada día un poquito mejor en nuestros pacientes. Bienvenidos, disfruten. Thank you very much, Doc.
So, buenas tardes. This is my only Spanish, I'm sorry. I'm pleased to be with you today, but you have the translation, so you can pick what I would say. And before starting, I want to thank the organizing committee from the Slanh and from the Fresenius Medical Care to organize this symposium on hemodiafiltration. And thank you for the kind introduction from Dr. Ana Aguilar. This is true. This is almost 40 years of development of a new therapy. But this is very important to remember, because from the last 2 days, I heard a lot of presentation, nicely presented, but sometimes the people are focusing on some removal rate of substances or looking on some biomarkers. But what we are looking is the patient outcome. What we want to improve is it's a patient life, quality of life, gaining the life, reducing the burden of kidney disease. So we are not looking just reducing some biomarkers, such as I would talk about the beta-2 microglobulin or different substances. So this is something a little bit different. And also, from my perspective, it's a very interesting looking on the CKD for the patient now. Because if you heard from the last 2 days, new medications are coming, and certainly the hope is to reduce incidence of new end-stage kidney disease patients in the future, or the medication. But also, if you look on the techniques, such as e-mode filtration, I will show you, we have now the proof that we can improve life, extending life, reducing by 23% mortality life, improving the quality of care, improving the quality of life, having a cost-effectiveness treatment. So we have good time for the CKD patient. So this is not every time you can say that. So maybe I can start, and okay, perfect. So what I would talk about is pushing the boundaries of high-volume hemodiafiltration. So we have a therapy which is high-volume hemodiafiltration, but I will start from the CONVINCE, which is the last findings, I would say the most updated finding, to the innovation of what we can do on a machine and on the filters. Because at the end, the therapy is something, but if you have some tools who can improve the therapy, it's easier for the nurse, caregivers, for the physician, and everything. So this is my disclosure. I just want to mention this is a scientific educational event sponsored by the Fresenius. I don't have too much clear conflict of interest, except I'm developing the hemodiafiltration for almost 40 years, as it was said. So the topic today is I will cover 5 elements. 1, high-volume hemodiafiltration. Why the high-volume hemodiafiltration is redefining a new dialysis standard. We move from the low flux to the high flux hemodialysis, and now you should look for high-volume hemodiafiltration. This is the trend. Second aspect, I will take this CONVINCE study to show that we deliver, and this is very impressive. This is almost the only therapy that has been shown such high level of clinical evidence. If you look high flux versus low flux, very small study, EMO study in US and MPO study in Europe, no more. Now you will see that CONVINCE plus all the studies which were developed around the CONVINCE is really a breakthrough for the scientific evidence. Third would be to show that a new dialyzer, and this is Coral or the FX Coral, a next generation or advanced next generation of filters showing that you can still improve the therapy. Clinical excellence meets sustainability, and this is very important because it was talked in Europe, and maybe if you are following the Nephrology, Dialysis and Transplant Journal, there was a controversy shown by the UGL group a few months or a few years ago, 2 years ago actually, saying that hemodiafiltration, this is a way to consume more water. And I will show you this is completely wrong, because at the end, the way to maintain high sustainability is to provide high volume hemodiafiltration. More you increase the convective volume, and more you can reduce consumption of water. This is not easy to understand, but this is reality. And then shaping the future for personalized and precise, I would say, therapy. So the first topic is high volume hemodiafiltration, to show that at the end we can move and change a little bit something. So I don't want to go into different detail of action, because of course, if the hemodiafiltration do something different to the patient, there are mechanisms behind. I will not talk about removal of substances, prevention of inflammation, and so on. I will show some element, but just to want to support this finding by strong scientific evidence. Everything is evidence-based. It's not, I would say, speculation or hope. This is based on the science. A randomized study, individualized or individual patient meta-analysis, so everything is related or real-world evidence. Everything is based on facts, okay? And also, I will show you, again, based on the CONVINCE, that clinical implementation of hemodiafiltration is not so complex. And you will see in the convince, some centers did not were exposed in the past to hemodiafiltration. They were able to implement hemodiafiltration in almost 1 or 2 weeks. At the end, 90% of the centers who were involved in the convince were able to maintain the technique and to achieve the target. So it's not so complex, okay? Now, what we learn. First element, high volume hemodiafiltration. So you have to understand that there are some intermediate outcome or explanatory mechanism. This is the intermediate outcome. We know that hemodiafiltration with the convective clearances, you can increase removal rate of some substances, but particularly middle and large molecular substances. Hemodiafiltration is not to increase urea, is not to increase KT/OVV. This is to remove something different, okay? And particularly in this element, I will insist on some substances which are easy to measure, strong markers of risk. This is beta-2 microglobulin. Yesterday I heard, and this is a nice marker. So we know that hemodiafiltration, depending on the convective volume, you can increase almost linearly the efficiency of your technique, okay? Hemodynamic stability, this is clear. One of the most evident clinical benefits when you start hemodiafiltration with your patient is the hemodynamic stability and the patient perception. As soon as you move from regular hemodialysis to hemodiafiltration, the patient feels much better, hypotension is reduced, and this stability during the dialysis session is improved, okay? Nutritional aspect is not only just looking on diet, but the preservation of albumin concentration, but also something interesting is linked to the physical activity. This is body composition. If you look inside the body composition with bioimpedance, it has been shown in a prospective study that you preserve muscle mass. And this is tremendously important for the dialysis patient to prevent frailty. Facilitate phosphate control. I don't want to say this is perfect, but more you give convective volume and more you are facilitating the control of phosphate, you improve the efficiency of vitamin D. And also another aspect, this is the last point, to reduce uremic symptomatology. So you, for the patient side, you reduce a lot of burden associated with symptomatology. Again, hemodynamic stability, but also the patient feels less fatigue after the dialysis session. They get less exhausted. Okay, so this is a part of element. But the most interesting one, this is patient outcome, the hard clinical outcome. We know that hemodiafiltration has improved survival. I will come to this point. But remember, 23%, this is exactly what semaglutide do with a diabetic patient. So we are at the same level of reduction, okay? So if you are impressed by pharmaceutical company, why not be impressed by medical technology, which are much more complex? Improved cardiac health. We know that cardiac risk is reduced and cardiovascular mortality. Enhance immunocompetence, very importantly, that has been shown partly by the convince, showing that during the COVID pandemic, because unfortunately the convince study was developed during the COVID pandemic, it was observed that the patient treated by hemodiafiltration get, I would say, better protection. They get responses to the vaccination, and the death was a little bit less when they were exposed to hemodiafiltration versus hemodialysis. So there is part of the immunocompetence. PROMS, I will come to this point, patient-reported outcome measurement, also improve, and the cost effectiveness, I will cover this topic. So now, this is just a very simple visual to show that at the end, whatever you look, from the randomized, from the meta-analysis, from the individual patient meta-analysis, real-world evidence, whatever you look, everything is positive. So there is a strong signal that hemodiafiltration, provided you develop the high volume, so we will talk about this element, which is minimum in Europe, 23 liters, then you improve all these parameters. There is no study showing the opposite, no one. So if you find a study, I'm happy to show please show me that there is a negative impact of the hemodiafiltration. Okay, so based on the convince and the individual patient data meta-analysis, which is coming from a pooling project, so the 5 randomized study in Europe, including the convince, which already cover more than 4,000 patients, so that means more than 2,000 patients receive the hemodiafiltration, has shown clearly that the survival benefits provided by the hemodiafiltration is linked or correlated to the convective volume that it delivers. So this is hazard ratio on the y-axis and the convective volume on the x-axis. And I put the convince, which was set at 23 liters, but there is no, I would say, conflict. If you want to increase the convective volume, you can again improve the survival of your patient. So you can improve the life gain to your patient. Convince was set to 23 liters as a minimum. So to be clear, we know what is the minimum of the convective dose. We don't know what would be the optimal or the maximum to achieve better life of your patient. Just remember this graph. Those convective dose related, it's matter for improving the outcome of the patient. Now, what you have to understand, hemodiafiltration is not a magic name. So it's not because you put hemodiafiltration that you save the patient. You need to provide optimal hemodiafiltration, and the optimal hemodiafiltration relies on these 6 key features. The blood flow, more you have a high blood flow, certainly more you are achieving the target, and the more you provide a blood volume process, which is beneficial for your patient. Diazer membrane makes sense, not only the membrane, but also the design of the filters. HDF machine, so the technology we support. Electrolyte composition, I will not cover this topic, but certainly we can discuss. Anticoagulation and treatment time. So now, I will not cover the treatment time. I will move on what is important, the convince, and focus after that on the diazer and the machine. So what is a convince? And I'm sure you have read, and certainly you know what is a convince. So the convince, certainly, and beyond, is a landmark trial. So if you look on the literature, this is a very important study in the development of any kidney replacement therapy. I talk about the EMO study, I talk about the MPO study, then the next is clearly the convince. It confirms the clinical benefits. I will cover this element. Primary and secondary outcome. The secondary outcome would be developed a little bit more, but I will show you this element, and particularly from the patient side, patient-reported outcome. Because in the past, if you look in the literatures, I mentioned the EMO study or the MPO study, nobody were caring about the patient perception. In the convince, this is the first study showing that not only the hard clinical endpoint of the patient were covered, but we address the patient perception, how the patient is feeling, how the patient is recovering, what is wrong with the treatment, okay? And the last point, which is also new, cost effectiveness, because the question is coming. Is the techniques so expensive, or is it more expensive than a regular one? And what could be the beneficial of using the hemodiafiltration? This would be addressed in this element. Updated IPD for individual patient data meta-analysis, as I showed, the convective volume, has validated what it was observed and convinced. So now we have the proof, and certainly no more study will be necessary to confirm that the superiority of the hemodiafiltration is coming. But remember, convective dose matters. We need to achieve the target. So the convince was developed and supported by European Union Foundation. So in the Horizon 2020, that was submitted to the European Union, and the convince project ranked first. This is the first time that kidney replacement therapy achieved such high level of this granting system in Europe. And why? Because that was a combination of hard clinical endpoint, mortality, hospitalization, and whatever, and patient-reported outcome. That was the first time that in a study of dialysis patient, such metric was introduced. Not only introduced, but introduced with a new technology, because the prompts is not so easy to fill forms. That was supported by digital system. I will show you some element with a tablet. And the design of the study is presented. Initially was planned to get 1,600 patients, but unfortunately, as I mentioned, the study started almost 3 months or 4 months before the COVID pandemic. And then you can imagine what was the complexity to develop a study when all the centers were locked and it was almost impossible to circulate, it was impossible to do anything in Europe. But still, we maintained a study and we were able to achieve 1,360 patients as shown on the slide. Hemodialysis was high flux hemodialysis with a KT/V which was set more than 1/4. This is European best practice guideline, and the hemodiafiltration was set to develop or to deliver in post-dilution mode more than 23 liters per session, because 23 liters was perceived by the previous IPD meta-analysis as a threshold to get a beneficial effect on the patient. Outcome, as mentioned on the slide, primary was all-cause mortality, secondary was cardiovascular, infection, and also patient-reported outcome. So that was the element. So just the study was maintained for 3 years, so that means we follow the patient 3 years, and then we get the result and the publication in New England in 2023. Again, very original from a study, as shown on this slide. 8 countries, 61 clinics, merging or mixing academic centers and industry partners. B. Brown, Fresenius, academics in the Averum, and different clinics from London, from UK, from Netherlands. So it was, for the first time, a mixing of academic and industry centers already. Then the design of the study, I don't want to go in a very more precisely, but very importantly, if you look on the top, you see 1,407 patients screened. And at the end, you see 1,360 patients enrolled in the study. And this is the first study where more than 97% of the patients screened were enrolled in the study. Just remember this number. If you look in the drug, and this morning I was attending a session, usually it's about 30 to 40% from the screening to the enrollment. Here we get 97%. Why? Because the magic question asked to the centers was to the physician in charge of the center, put the name of your patient who can achieve 23 liters per session. Just this question, and the physician selected the patient. And then a randomization was performed by centers and according to the different centers to achieve a balance between hemodialysis and hemodiafiltration. So just remember this very original element. Patient characteristic, I don't want to go into detail, but age is about 62. Maybe it's a little bit younger as compared to the general population in Europe. So this is a mix of Western, Eastern, Southern part of Europe. So there is a mix. Cardiovascular, diabetic patient, so alcohol consumption and so on. But if you look on the high volume hemodiafiltration on the left and high flux hemodialysis, this is perfectly well balanced. So the randomization works perfectly. There is no imbalance, okay? Second aspect, the characteristic, I put that some patients get residual kidney function. Something wrong with the slide? I see, okay. Some, as indicated, some patients get residual kidney function, but this is not the main part of this element. Very importantly, I put this vascular access. 82 to 83% patients get native fistula or graft, but the percentage of catheters is limited to 13. I don't know what are your practices in South America, but I know that in Europe, it's not usual. If you look in Europe, 20–25% of the patients are treated on catheters. Again, that could be a selection. We can discuss this point, but still, patients treated by catheters achieve the same convective volume as the patient treated with a fistula. This is the important factor. Now, based on the finding, as I mentioned, KT over V was set to 1.4. If you look, the high flux hemodialysis patient, the patient with the KT over V was almost 165, 0.2 over the target, and a patient receiving hemodiafiltration was 175. So without any P or any statistical, you understand that just by delivering high volume hemodiafiltration, this is not the main target, but necessarily you increase the efficiency of removal of urea, so small molecular substances, you increase by almost 10%. Okay, easy to understand. And the second observation is the fact that it was very stable over the time. You see, consistently the patients were maintained at the same level of this efficiency. Again, second metric is the convective volume. The yellow line, this is a 23 liters set as a minimum. And you see that the patient get 25.5 liters and very consistently over the time. More than 90% of the patient, 95% of the patient get this convective volume consistently over the time. There is no discussion about achievement. Why there is a difference? The 2.5 liters between 23, 25.5 is just weight loss. You understand that the substitution is one aspect and the ultrafiltration is the other one. So the net ultrafiltration is about 2.3, 2.5 liters. Again, the main outcome of the CONVINCE are summarized. So death, the primary outcome was the death, all-cause death. As shown, there is a reduction of 23%. I will show you that on the graph. Cardiovascular, there is a trend to reduce mortality. Unfortunately, as you can see on the slide, this is not significant. This is why I put dotted line. But interestingly, non-cardiovascular deaths are highly significant. And in a non-cardiovascular death, one important factor is the infection. And as I mentioned, COVID was the patient who get treated by hemodiafiltration get better protection on the COVID. So I don't want to go into detail of this element. Certainly we have some mitigation in the death cause, as the patient who get COVID at the time were hospitalized and they died in the hospital or the clinic. And certainly when they died, the physician put COVID positive. So there is certainly some mix between the COVID and the cardiovascular death. But still, remember, if you get treated by hemodiafiltration, there is a protective effect against the COVID infection. This is a slide just to show that high-dose hemodiafiltration do better than high-flux hemodialysis in reducing the mortality, all cause, 23%. But the very important factor from my side, if you look on the curve, this is the dissociation of the curve. So the beneficial effect is not after 1 or 2 years. The beneficial effect of the hemodiafiltration starts almost 2 to 3 months after the initiation of the hemodiafiltration. This is very important. Just to understand that hemodiafiltration certainly has some cardioprotective effect, okay? It's not after 1 or 2 years, but you see immediately that after 3 months, there is a discrepancy between high-volume hemodiafiltration and hemodialysis. So, good point to understand if the hemodiafiltration do something, this is about the prevention. So we are not able to cure something which is already established, if you have arteriosclerosis, if you have a coronary disease, but if you start earlier, then you prevent the cardiovascular mortality. As I mentioned, patient-reported outcome was measured, and this is completely new. I did not see any study in the world in dialysis showing a analysis from the patient reported and the patient perception. And that was performed with a new system, which is called PROMISE, which is based on the US. And based on this PROMISE, this is a computer adapted and adaptive interactive system, meaning that it's supported by the web, artificial intelligence, and the system is adjusting the questionnaire to the patient perception, meaning that maybe the first time, the questionnaire could take maybe 30 minutes, but after 2 or 3 questionnaires, it's reduced and focused on the patient, I would say, concern. And this is very important. So this is a new, meaning that beside the development of the PROMISE, the group of Berlin, Professor Matthias Rose and his team developed a new questionnaire specific for the kidney patient, because the questionnaire from PROMISE was not intended to be developed for kidney patient. So this is tremendous work. Took almost 1 year to develop the questionnaire, make this tablet as implementation and making analysis. Okay, so understand that very originally. And if you look on these prompts, this is just published by the group of Matthias Rose in Kidney International last year. You see some elements. So, of course, you could be disappointed. If you look on the, and again, I did not mention, but analysis of the prompts was done every 3 months. So it's not at the initiation and at the end. So we have a complete analysis of the trend. Every 3 months, a patient gets report on this analysis. Also very original. Unfortunately, when you see the slide, you said, okay, poor dialysis patient. Everything is wrong. There is a decline of almost every, I would say, physical, cognitive function, fatigue, and everything. Okay, this is what you observe. Unfortunately, hemodiafiltration, as I said, is not miraculous. Certainly, it's not transplantation, but still. Now, if you look inside, and particularly you follow the blue line, which is reflecting the hemodiafiltration, every time you see that there is a difference between, I would say, symptomatology. Physical functioning is better. What is very impressive, this is why I put the highlight in yellow, this is a cognitive function. Cognitive function, there is a decline, and then there is a rebound, and there is a stabilization, meaning that certainly this cognitive function, which is affecting regularly our patient on dialysis, and certainly part of the dementia or the local arcariosis that you get in the brain, certainly there is a protective effect on the hemodiafiltration. Fatigue, also, if you look, there is a fatigue, I would say, which is reduced. Sleep disorder is improved. Unfortunately, it's not completely corrected, but still there is an improvement. And again, if you look on all other elements, anxiety, depression, pain interference, every time there is a beneficial effect of the hemodiafiltration, and particularly social participation. This is very impressive. And certainly this is reflecting that the patient after the dialysis session get better feeling, time of recovery is reduced, and that permits to the patient to go in the family or to go to the work or to go to social activity, and the recovery is much better. So social participation is improved in this element. Just a brief summary to show that physical health or mental health is better preserved. So there is a mitigation effect of the hemodiafiltration on the as compared to hemodialysis. Okay. Now the third point, which is completely new, is the cost utility and the cost effectiveness. I'm not sure that you are familiar with this concept. I'm not, so I'm trying to put in a very simple way. But of course, when you develop a new therapy, this is the case for a new medication or the case for a new therapy such as hemodiafiltration, you would be interested to know if it's more effective and less costly. So that means if you look on this 4 quadrant, you will be interested to get, I would say, on the southeast part, you are more effective and you cost less. But unfortunately, this is not the case. So you have to accept that a new medication or new therapy could cost more, But the point is to make sure that the costs that you bring to your patient improve the quality of life, extend the life of your patient, and the cost of the treatment is associated with the life gaining. Okay, you understand? And then the group of Amsterdam developed this cost-effectiveness analysis, and then you need to define what is called ICER, which is the incremental cost-effectiveness ratio. What does that mean? This is a cost that you put in your patient to improve or to gain 1 year of perfect life, okay? And then if you put this straight line or dotted line, this is the ICER, the slope of the ICER. This is what the society is willing to pay to increase your life of your patient. Okay, so that depends on your cost system, depends on your social environment, and the study was performed in Europe. So what I will say is focused on Europe, is focused on the social and healthcare system of European. Maybe it's not applicable to South America. This is a limitation of this element, whatever. The analysis was performed using data from, UK, Netherlands, and some of US to understand what is the cost of one QALY. So if you gain 1 year in perfect health, what is the cost that you accept or your social security is accepting to pay? And if you see from the different country, in UK it could be 20 to 30,000 pounds, in Netherlands is 80,000 pounds, in US is 100,000 to 150,000 pounds for one QALY. So depending on your country, this ICER could be different, whatever. Now, based on this trial, 2 years, the analysis shows that the cost of gaining 1 year in perfect life was 37,000 euros. Okay, this is what we paid, and thus the society is accepting to pay. I will show you that in a minute. So this is the extra cost or the additional cost, if you want, to pay. Now, according to the lifetime, and then you see the different modeling. This is a model-based finding, so putting together, so it's between 33 to 36 or 37,000 euro. Okay, so it's very close and very, I would say, in line with what we observe in Europe. Now, if you put that in this probability of cost effectiveness, probability of cost effectiveness is on y-axis, and the ICER in the x-axis, you see that the cost, which was set at this between 40 and 50,000, I had mentioned, there is a probability to be cost effective of almost 95%. So we can say, based on European data set, that hemodiafiltration is cost effective, and the cost, the life of gain that you provide your patient will cost you, but this is associated with the life gain and not associated with the extra cost of the technique. Okay, so last point, and this is certainly the most strong evidence. This is coming from the Lancet, and that was analysis, what we call updated individual patient data meta-analysis. So this is a 5 randomized study selected in Europe. I don't want to go into detail, but altogether that's collected more than 4,000 patients, split in 2,000 hemodialysis and hemodiafiltration, with statistical analysis performed by Oxford Center, so completely independent. And what they show, the all-cause mortality, combining this element with high-volume hemodiafiltration, reduced by 16%. Cardiovascular mortality risk is reduced by 22%, and cardiac, particularly with the cardiac causes, infarction, arrhythmia, cardiac insufficiency, by 33%. All other all associated cause of death are not significant. Still, there is a trend. Infection as shown. There is a reduction of the risk of infection, but it's not significant. So statistics show you that the beneficial effect is on all cause and particularly cardiac protection. And again, if you look on this subgroup analysis, I don't want to go into detail, but all cause mortality, whatever you select, the male or the female, younger, diabetic, non-diabetic, cardiac, you see the trend is almost beneficial for every category of patient. So what we can say today is that hemodiafiltration works as soon as you provide the right convective dose, has a protective effect, and that works in all categories of patient, young, old, diabetic, non-diabetic, cardiac, or whatever, okay? This is all cause, and particularly for the cardiovascular, this is the same as shown, it works. So that means when a therapy works, it works for everybody. So there is no question. Now, this is what we learned from the hemodiafiltration. To make the link with implementation, we move next step to the dialyzer. You remember the graph I put you, the dialyzer and the membrane. This is very important. And then I would put some innovation. When you look on dialyzer membrane, you need to have some innovation. So the coral filters is certainly, I will show you in a minute, cutting edge, I will say, dialyzer membrane. This is a new way of spinning the membrane, incorporating inside the polymer some new substances who can change completely the surface of the dialyzer. The permeability is the same, there is a preservation, but also this is not only just hope or speculation, this is supported by high clinical evidence. So that means a lot of study in vitro, in vivo, in patient, in different settings, hemodialysis, hemodiafiltration. And the last point, and not the least, by modifying this membrane, there is a change in the biocompatibility. And you know that the bioincompatibility may affect or harm the patient, and particularly by the complement activation, by the inflammation. So just understand this element. So the idea is to make a dialyzer now. I don't want to go into detail, to make sure that you preserve the efficiency in terms of removing substances, permeability and sieving coefficient and solute removal, to preserve some loss. And I don't want to go on the detail, but the idea is to prevent albumin loss. Again, because yesterday was a discussion about the hemodiafiltration. It's not true that hemodiafiltration increases albumin loss. Completely wrong. If you select the right dialyzer, if you select the right machine, there is no albumin loss, at least in the range we want to do. Now, you have to remember, so this is one aspect, the efficiency. Next step is the dialyzer. It's not just a bio-exchanger, it's a bioreactor. As soon as you put your dialyzer in the circuit, in contact with the dialysate, you activate a lot of, I would say, protein cascade. I don't want to go into detail, but at the end, each session, there is an activation of the complement, is activation of the clotting, is activation of the, different, I would say, cells, kallikrein, and all this activation by some interaction try to mediate or release some mediators, and then at the end, this is 3 times a week that you create such bioreaction, which lead to or contribute to morbidity and mortality. So just remember, dialyzer is not just solute removal, it's bioreactor, and you need to be less bioreactive. And again, this is part of the element. I don't want to go into detail. So just remember 2 key elements, permeability and biocompatibility. And I will show you in a minute what we can do. Again, sometimes it's a little bit misleading. When you look on the permeability, and if you look at the leaflet that the manufacturer gives you as a dialyzer, they provide nominal permeability. So you know that the permeability has a sieving coefficient for any substances, which is X or Y. But the point is, of course, when you look on the effective permeability in vivo, this is different. So you have to understand that the functionality of dialyzer should be evaluated or assessed in vivo. And then, this is very important factors. Since the operational setting, the fouling of the membrane, protein deposition. So everything contributes to modify the permeability. And again, this is a very important factor. So just showing this element. This is very known figures showing the sieving coefficient and the impact of different membrane. But I will focus on one element because now if you select one substance, and my most favorite one is the beta-2 microglobulin, which is almost 12 kilodalton. If you select this beta-2 microglobulin, usually the filters, and particularly this FX coral, the sieving coefficient is 0.9 to 1, so almost permeable to beta-2M. But the next step is to understand what is wrong in the next step, and if you see the slope, and this is the sharpness of the slope that we have to analyze to understand what is the difference between what they call mid-cutoff membrane and the sharp slope high flux membrane. Because the point is to make sure that there is no albumin loss. So the techniques and the engineering and the very smart engineering of this new spinning process is to make sure that you have a very sharp slope maintaining the permeability for the solute, but restricting albumin loss, okay? So what, again, there is a performances. I don't want to go into detail, but you have to understand that membrane is one aspect, but the geometry of the diazer, the association of the fibers, the condition, the operational condition of anticoagulation can change completely the element. Now, very importantly, again, yesterday I heard a discussion about this HDX or mid-cutoff membrane. There is no magic. I put on the left side, and if you are interested, you can read what I wrote a few years ago. On the left side, you get what we call external hemodiafiltration. So that means this is exactly what a convince developed. This is a post-dilution mode. You extract ultrafiltration and you substitute in post-dilution mode, and you have a very controlled system. Everything is controlled. You know exactly what you do. If you want to do 23 liters, you do 23 liters. So you know exactly what the dose of convective volume you deliver to your patient. On the right side, this is called HDX or expanded hemodialysis or whatever. I don't care about the name. But this is a concept which was born 20 years ago. This is internal hemodiafiltration. Then you have this internal hemodiafiltration that you have with any capillary diazer. As soon as you have a capillary diazer plus ultrafiltration control, you get some internal filtration. Now, the point is, of course, if you increase resistance inside, you can increase this internal hemodiafiltration. So this is internal hemodiafiltration. But inside this internal hemodiafiltration, this is a black box. You never know what you do. If your blood flow is low, the exchange is very limited. If you want to make sure that at the end you want to achieve the target, you need to have a maximum of blood flow, which is 400. And then if you look at the study which were performed with this type of diazer, at the end the convective volume is between 4 to 7 liters per session. So I agree, it's internal filtration, this is a convective therapy, but with very low convective volume, okay? Now, moving to the membrane. This is a new trend. There is a science about the polymers. You can graft on the polymers, you can graft through the membrane, or you can modify the surface of the membrane by the spinning process. This is a technology, I will show you in a minute, where you can put inside your polymers and you can change some element. And the next technology will come with a multi-layer system. I don't want to go into detail, but certainly after the hemodiafiltration, that would be a new therapy with hemo adsorption inside the membranes, but that would be the future. So looking now what is new with this membrane. This is a spinning process. And the spinning process, of course, you get the polymers, you get these fibers, but inside what was done in this new technology is to enrich the polymer with a PVP, polyvidone pyrrolidone. But to stabilize this PVP, it was stabilized with alpha tocopherol, vitamin E. So if you increase the concentration of PVP inside your membrane, and you stabilize the PVP to prevent leaching of this PVP, then you change completely the membrane. And you change particularly the surface of the membrane, and by changing the surface of the membrane, I will show you in a minute what that do. This is very impressive. It's creating at the blood interface what is called a sort of hydro layer formation. So that means you have hydrophilic membrane. And if you create hydrophilic membrane, that means that you reduce protein deposition, you reduce platelet deposition, you reduce a lot of activation on this contact. So just by the spinning process, you can change such element. Does that work? And of course, this is clinical study. It works on the complement activation. This is a comparison between the old cardiacs, different filters. I don't want to go into detail. In the activation of the complement and looking on the anaphylatoxin, C3A, C5b, and certainly more interesting, SC5b9, which is last part of the complement. And as shown, there is a reduction of the complement activation. So in vivo, showing that certainly it works. This is the kinetics, again, showing that the initial activation of the complement, which occurs within the first hours, is completely reduced, significantly reduced, and is maintained till the end of the dialysis. This is one aspect. Again, as I mentioned, the idea is to reduce protein deposition and platelet deposition. That was done in ex vivo biocompatibility study, showing that platelet deposition is reduced on the membrane. So the point is, if you reduce protein, there is no way for the platelet to adhere or to stick to the membrane. So you reduce this bio layer formation, which is done as compared to the different one. And again, significantly reduce the complement activation. This is ex vivo, as I mentioned. I don't want to go into detail, but this is true. Another point, which is a safety issue. The idea is to reduce now the albumin loss. And this is to compare the albumin loss and looking on the dynamic of the change in the albumin. This is ex vivo, this is not in vivo, but just to show, comparing the different diazer, that the new membrane has the lowest albumin sieving coefficient. And we know that albumin loss occurs within the first hour. 60 or 70% of the albumin loss occur within the first hour of dialysis. And if you look, clearly there is a reduction of the albumin loss on the left side by the kinetics, and the total change of the albumin sieving coefficient during the dialysis on the right side. So we know that albumin is, there is no concern about albumin loss. And now this is one of the last studies showing that the use of the filters in hemodiafiltration, comparing different filters, and looking on the removal rate of beta-2M, filters in that case were surface limited to 1/6 square meters, I think so, show that at the end, the removal rate of the beta-2M is maintained as compared to the regular and is over or significantly higher than the comparators with a different polyflux or surflux. So that means we know that biocompatibility is improved, removal rate of beta-2M is preserved in this element. Just to show that at the end, you can get in hemodiafiltration that was performed in hemodiafiltration almost 76% of the reduction rate of beta-2M. So this is what we learn. Now, as I mentioned, using hemodiafiltration high volume, the question, does the technique is sustainable over the time? The consumption of water is a concern. And I will show you that this is a wrong concept, since the hemodiafiltration is a way to save water. Again, this is focusing on a machine. Now, the point is, of course, in a hemodiafiltration machine, you need to use what I call smart hemodiafiltration machine with the two key features. One is a way to make sure that the substitution or the ultrafiltration is controlled, and I will show that in a minute for the Fresenius, is the AutoSub Plus. This is a way to ensure that every second or every time the machine is extracting the maximum from the patient. So filtration fraction, which is a magic name, is maximized during the hemodiafiltration session. I will show that in a minute. So remember, AutoSub ultrafiltration control maximize the filtration fraction. And the second aspect is autoflow. And this is to align diazide flow to blood flow. Since if you are using a very low blood flow, there is no need to use high diazide flow. This is a waste, since we know that there is, I would say, ratio between the efficiency and the blood flow and the diazide flow. And the combined impact, and this is a tremendous beneficial effect of hemodiafiltration, this is a way to increase filtration fraction, so to increase the convective volume, I will say in a minute, and to reduce more the diazide consumption. Okay? So this is summarized on this slide. On the top, you get automated ultrafiltration control, which is a way to permanently increase the filtration fraction. And the filtration fraction could be 30 to 35%. So 1/3 of the blood which is flowing the dialyzer can be extracted. This is possible just by the AutoSub system, where they get a sensing to the dialyzer with a variation of the viscosity. You cannot do that in other techniques. If you don't get this sensing system, you cannot achieve such element. I will show you. And the second part, this is the bottom part, this is the way to optimize diazide consumption. Diazide to blood flow. I will show in a minute. The AutoSub was tested a few years ago by Maduel. And clearly, when he makes this analysis, on the left side, this is the old software from the 2008 to the new software with this AutoSub. And you clearly show that you can increase by 4 to 5 liters the convective volume in the same treatment time. So 4 hours or 4.5 hours, no way, you increase by 4 to 5 liters without any change. That works with a fistula on the right and with a catheter. So whatever you look on the right side, it works in the same way. But catheters, you get a little bit less increase, but there is a beneficial effect. So now, to understand, achieving 25, 26 liters is not so complex, which I would say the right ultrafiltration control machine. This is one aspect. Second aspect, why the interest of the hemodiafiltration? On the left side, this is urea. On the right side, this is beta-2M, beta-2 microglobulin, and you get clearances. And what you see with the same blood flow, diazide flow, which is put on the bottom, you can reduce the diazide flow while you increase the clearances of the substances. Why? Because if you look on the right side, unfortunately I cannot see with this pointer, by the way, you see that when you get 35% of the filtration fraction, you increase your clearances of beta-2M by 63%. So that means same time you reduce diazide flow down to 400, and then you increase. And this is very simple. More you increase the filtration fraction, more you increase the saturation of your diazide. Okay? Unfortunately, we cannot get more than 35%. This is the maximum from the physiological effect, but still show that this line, and this is confirmed by different, I would say, internal study, that you can reduce the consumption of diazide and, of course, the water. And this is based on what we observe in a CONVINCE. In a CONVINCE, left side, we get hemodialysis with a consumption of water which was estimated to 120 liters per session, 600 times 4 hours. Hemodiafiltration was 120 plus 23 liters, 143 liters, if you add this 100 ml as a substitution volume. Now, if you make futuristic analysis and then you move to optimize hemodiafiltration using auto substitution plus autoflow, you see that you can preserve the efficiency in terms of KT/V and clearances of beta-2M while you reduce the consumption of water by 50 liters. So at the end, with 100 liters of hemodiafiltration, you achieve the same efficiency and you save 50 liters of diazide. And if you multiply 50 liters times 150 times a year, you save almost 2,000 liters of fluid per year. And again, just to finalize and make sure that you are not confused, I put on the right side everything which is linked to online hemodiafiltration with the membrane, the convective clearances, in terms of what we know, the filtration fraction, we know that it's stabilized, 30 to 35% diazide to blood flow optimization. So all the options that you can have on the online hemodiafiltration to make sure you achieve the target. So it's not just speculation. This is real fact. And on the left side, I put what you can achieve, which is MCO filters, the HDX. Everything is, I would say, depending on the resistance inside the filters, depending on the operating condition. And even at the best, if you get 400 ml of blood flow, the maximum that you can achieve inside the convective volume is about 7 to 12 liters for 4 hours. Okay? So at the end, you have a black box versus something which is very clear. And just to shaping the filters and then, of course, ending this discussion, I would say, it's clearly shown that high volume hemodiafiltration is clinically superior, supported by the CONVINCE and the different IPD meta-analysis. There is no concern about superiority of the hemodiafiltration versus high-flux hemodialysis. There is no more question. Survival advantage has been shown. You reduce mortality, all-cause cardiovascular, particularly the cardiac one. You mitigate the quality of life for a patient. There is a decline, I agree, but you preserve the patient-reported outcome, certainly better. We have the cost utility. We know it's cost-effective. Now you have a new dialyzer with a new membrane, which offers enhanced permeability and better biocompatibility. You have smart hemodiafiltration machine with option, can improve the performances, can achieve more sustainability if you use the right opportunity, the right function of the machine. And then you can have a more personalized, precise, and sustainable approach based on this new technology, new filters. Then you can select your patient and you can adjust what you want to give to your patient in terms of convective volume. So this is a turning point from my perspective, and we need to shift to hemodiafiltration. We now have the evidence that the technology and the tools are there to push the boundary of dialysis care. Now, you have the tools, the information, the evidence is up to you to implement. CONVINCE has confirmed that convective volume is very important. Convective minimum 23 liters can be the new standard of care. Coral smart hemodiafiltration machine paves the way for precision and personalized care. For future focus, I would say dialysis should be certainly more effective, patient-centered care, resource efficient, so you need to adjust according to your healthcare system and your facility opportunity. I cannot make that for you, but it's time to embrace high-volume hemodiafiltration as clearly a transformative solution in renal replacement therapy. And by the way, I want to thank you for your attention, and maybe with questions. Thank you very much.
Muchísimas gracias. Sí, thank you very much. Merci beaucoup, Dr. Canaud. Muchas gracias. Tengo preguntas por acá, pero también tengo mis compañeros. Ay, no me van. ¿Alguna pregunta desde el público? Ya tengo preguntas, tengo acá. Pueden hacerla en español porque el doc tiene aquí su traductor, sin ningún problema. Si no, yo, doc, voy a ir haciendo y ahora leo por acá. No, está todo perfecto. Sí, ya está. Muchísimas gracias.
How you put that?
I don't know. A ver.
No. Ah, okay. Bueno.
Okay.
Thank you.
¿Ha habido alguna pregunta sobre el uso de esta membrana? ¿No? ¿No funciona? ¿Sí o no? Volume. Ahora sí. ¿Me están traduciendo? ¿Sí o no? ¿Sí? ¿No?
Yeah.
Yes? Ah, ok. Thank you. Para empezar por el coral, por la nueva membrana, mejor compatibilidad, han hecho preguntas sobre si hay experiencia de uso en esos pacientes que tuvieron alergia en el pasado a algunas membranas y fueron cambiados a triacetato de celulosa, si existe alguna experiencia, si tienen algún papel en esos pacientes que tuvieron reacciones alérgicas.
Okay. Yeah, that's a good question. And part of the biocompatibility is to prevent such, I would say, hypersensitivity reaction. And particularly in the past, it was observed with a different type of membrane, a cellulosic membrane, or even polysulfone membrane in Europe. 5 years ago, 6 years ago, we had some, I would say, small epidemic of hypersensitivity reaction. And it has been shown with now the implementation of this new type of membrane enriched with the poly-PVP stabilized by the vitamin E, there is no more reaction. So we can interpret that type of reaction was certainly linked to some remaining or complement activation at the past. So clearly moving some patient with a hypersensitivity to the new membrane, this is an opportunity to prevent such, I would say, sometimes stressful for the patient, or even, I would say, endangering the life of the patient if you get, I would say, high hypersensitivity reaction. So this is a nice opportunity to switch patient with a hypersensitivity to any membrane to the new one. This is an opportunity, and certainly will be interesting to be tested. But in Europe, the membrane has been introduced almost 2 or 3 years ago, so there is 1 million of sessions, and it's clearly shows that there is no more, I would say, any concern about any hypersensitivity reaction. Yeah.
Perfect, thank you. ¿Hay alguna pregunta que no veo en la audiencia? ¿No? Han sido tímidos porque aquí sí tengo. ¿Han hecho alguna pregunta, doctor Canaud, sobre el manejo de la hemodiafiltración en poblaciones diferentes, no tan habituales como las embarazadas o los niños? Pregnant women and children.
This is also, I did not address this topic, which is a very specific one, but of course, if you look on the pediatric, I will start by the pediatric population. Now, in Europe, and certainly will come in US, the new standard of care of kids, patients on dialysis is to start by the hemodiafiltration and to have a daily hemodiafiltration. So this is a new standard of care to be sure that the patient get better, get a nutritional aspect, growing, they recapture the growing rate, and this is a way to bring the pediatric population or kids to transplantation in a better shape. So for the pediatrician population, this is clear, hemodiafiltration is the first choice. Now, in a different population, and particularly the pregnant population, this is not really a concern in Europe because the population is far from pregnancy. But still, I know from Latin America, you have a lot of experience with the pregnant. Hemodiafiltration could do better. Could do better because this is a preservation of the hemodynamic stability, so you reduce hypotension, and then you prevent, I would say, ischemic stress of the placenta. But again, for the hemodiafiltration in a pregnant woman, what is need to be considered is not just hemodiafiltration, but daily hemodiafiltration. Because daily hemodiafiltration prevents the fluid fluctuation, prevents this tonicity change, prevent all these elements. So the best treatment that you can provide for pregnant women is to start hemodiafiltration And certainly, as soon as you have this opportunity, move to daily hemodiafiltration. And daily hemodiafiltration does not mean you do 4 hours every day, but maybe 2 to 3 hours every day, 6 times a week. This is a perfect fitting for a pregnant woman. You stabilize the volume, you improve or you reduce the fluctuation of different biochemistry. There is a way to improve nutritional aspect. There is no concern about the pressure control. And this is a nice way to make sure that at the end you conduct the pregnancy to the term and you get a baby. I remember there is an experience from Colombia or Argentina where they follow 3 pregnant, and the weight of the baby at the end was 2.5 kilo, which is almost normal.
Yes. Ok. No preguntas. Ah, ya. ¿Alguien le puede alcanzar un micro, por favor?
Buenas tardes, ¿qué tal? Les saluda Héctor Peña, enfermero de Perú. Tengo una pregunta para usted. Con la evidencia del estudio CONVINCE, ¿qué cambios considera más relevantes en la práctica de enfermería, en hemodiálisis, al implementar esta HDF de alto volumen? Gracias.
I did not get the point. Okay. I'm sorry, I did not get the nurse. And this is clearly, I would say, I did not mention this element, but hemodiafiltration is almost easy as regular hemodialysis, because at the end, if you select the right machine, you don't have to make more than pressing the button on the hemodiafiltration. So the time for the nurse, the workload for the nurse is even reduced, because what I didn't mention, you have the online production of the substitution for the hemodiafiltration, who could be used for priming your system, priming your dialyzer, rinsing back your dialyzer to patients. So at the end, you can reduce workload for your nurses. So at the end, they can save time just to make setting of the dialysis or the hemodiafiltration machine. And there is no more handling needed. You don't need any more saline for the priming. You don't need any more saline for the rinsing back for the patient. So for the nursing time, I think you can save a lot of time. This is our experience, and there is, I don't see any difficulty. Everything, the interface of the dialysis machine is very friendly, so at the end you just select and you get almost, I would say, for the nurses, doesn't make any difference as a regular, and even better, you can save time.
Muchas gracias. Por allá.
Buenas tardes, Pedro Vargas de CLICOP. Hace aproximadamente 2 años en mi país hemos venido, 7 años, venimos de conocer la hemodiafiltración y recientemente era un condicionamiento que teníamos en una lucha frente a un contrato muy grande, pero muy grande, y la verdad que como sociedad, como pacientes, nos sentimos un poquito ausentes del acompañamiento técnico y de la valorización de la importancia que significaba para nosotros entrar en esta tecnología. ¿Cómo podríamos hacer nosotros como sociedad, como pacientes, para que esto realmente pueda, ese acompañamiento y ese interés que tenemos nosotros por contar con ello, realmente sea acuerpado por nuestros propios nefrólogos?
That's an excellent question. Again, I did not address this point, but of course, as patient association, you need to act with the scientific society of your country, Ecuador or different country, to make sure that you can make an action on health regulatory system of your country. To say, okay, now we have the evidence that the technique or the treatment, I don't like the term technique, the treatment is better. There is a way to preserve quality of life, to make sure that the patient feels better, to increase life expectancy. So there is no, and the cost, it's almost comparable to the regular hemodialysis. So there is no, you have the evidence. The point is to make sure now the health regulatory system or healthcare payer accept such a discussion. But this is part of different, I would say, country perspective in Europe, for example, we don't have any restriction or limitation. But in some country of Europe, Romania, for example, they had some restriction to the numbers of patients put on hemodiafiltration. But now, after the convince, they just open because they use scientific evidence to show that at the end, the technique is better, you improve the quality of life, you improve the life expectancy, and so on and so on. There is no, I would say, contraindication for the hemodiafiltration. It would be the same if you know that a medication, I don't know, the semaglutide, for example, is better. If you don't use the semaglutide, there is loss of chains for the patient, and then it would be the same for the hemodiafiltration. If you don't use the hemodiafiltration, there is loss of chains of surviving in a good health or good life for dialysis patient. So that should be an interaction between patient association, which is a voice, and the scientific society of your country or your nephrologist to go together to the healthcare authority and to show that at the end the evidence is there. And then if you don't use evidence at the end, patient get losses of chances of surviving. So this is, I know, politically difficult to implement, but this is the only way to act. Evidence is created. There is no point. I don't know if...
Muchas gracias. Por allá, another question.
Buenas tardes. Franklin Mora, de Ecuador. Los estudios han demostrado que no es lo mismo dar 22 litros de volumen convectivo contra 25. Obviamente 25 es mejor, ¿no? Y con respecto al flujo extracorpóreo, al QV, está permitido dar entre 350 y 500. Yo entendería que dar el mayor flujo extracorpóreo con el mayor volumen convectivo es lo mejor. No sé si valdría la pena hacer un índice dividiendo el volumen convectivo para el flujo de bomba y ver diferencias de mortalidad en pacientes que reciben más diálisis con convección y también con flujo extracorpóreo. Doctor.
Okay, maybe I did not get right your point. Maybe this is a point of the translation. If I understand correctly, you mentioned that the convective volume, higher is the convective volume, better is the survival of the patient. This is clearly shown. We know that higher convective volume improves the life expectancy of the patient and reduce mortality. Now, what you mentioned about extracorporeal, I don't understand what is the extracorporeal. You mean the extracorporeal circuit, or because I was not clear with that. So the convective dose, more you give to the patient and better is for the patient. This is the main message. But maybe you were mentioning the extracorporeal blood flow, which is high and could be harming the cardiac.
Flujo sanguíneo. La pregunta es sobre el mejor flujo sanguíneo. Blood flow.
Okay, now I get right. So there is no harm with the blood flow, no harm at all. Why? Because if you just think about what we do in dialysis, the extracorporeal blood flow is 150, 180 ml outside the body. When you prime your system with the blood line, the filters, and back, you get 180 ml of blood flow or blood volume outside. Now, when you put a pump, which is 200, 300, 400, still the volume will be the same. So there is no harm to increase the blood flow in your patient. There is no concern about this element. Okay, so more you get this blood flow, the extracorporeal blood flow, better is for achieving the target. But not only for achieving the target of the convective volume, it's better for the efficiency, because the KT over V, if you increase the blood flow, if you increase the blood volume treated per session, and if you move to 400 ml, 4 hours max, that you are treating 100 liters per session. And if you treat 100 liters, you get more efficient for the diffusive and for the convective. There is no harm at all for the heart of the cardiac system of the patient. Okay? Now, the point is, of course, if the fistula access or the access flow is too high, that's a different story. If you create a fistula with a flow which is 1.5 or 2 liters a minute, that's harming the heart of the patient. So my message is clear. Making a fistula with a limited flow, which is 600, 800, is fine. You don't have any risk for the cardiac system. And the blood flow outside 400 is perfectly fine. Now, having a fistula with high blood flow, this is a risk for the heart of the patient. Okay? So you have to dissociate what is extracorporeal circuit and what is access flow. I don't know if I'm clear.
Buenas tardes, profesor. Juan Santa Cruz, de Ecuador. He escuchado que usted topó el tema de costos, ¿no?, que es uno de los grandes limitantes en nuestro medio. Entonces yo quería preguntarle qué beneficios o qué podemos decirle a los gestores en que esta técnica, que claramente es superior, puede, a pesar de ser más clara, con sus beneficios, pues a lo mejor aminorar otros costos para que se equipare un poco la balanza y poder implementarla. Y una cortita más, ¿merece la pena dar hemodial filtración a alguien que a lo mejor no tiene un buen acceso vascular, en donde no podamos conseguir los 23, 25 litros? Porque nuestra realidad también es esa. Muchos pacientes tienen catéteres transitorios o catéteres tunelizados que como máximo dan 350 de flujo. ¿Merece la pena a esos pacientes darles la hemodial filtración? Gracias.
Thank you. This is a two good questions. The first one, I would say, the cost. What I mentioned about the cost effectiveness was based on European social system. But what I did not mention is the extra beneficial effect of the hemodial filtration. One, if you reduce inflammation, you reduce all the complications associated with the inflammation of your patient. Maybe this is a vascular disease, this is a malnutrition, so you have a lot of side effects, one aspect. Second aspect, based on this hemodial filtration, we know that you can reduce erythropoietin consumption. I didn't mention. But if you reduce not only EPO, but iron, if you reduce IV iron, if you reduce EPO by 20, 30%, a lot of studies shown, you see the impact on the cost. Now, if you reduce phosphate binders also, that was not part of the discussion. Again, because the efficiency on the phosphate removal, you gain 15% more phosphate removal. You cannot stop the phosphate binders. This is clear, except if you do longer hemodial filtration. But if you do the regular hemodial filtration, you can save 10 to 15% consumption of phosphate binders. Then you can reduce hospitalization associated with malnutrition, with inflammation, with erythropoietin, and so on. So this is a lot of elements that maybe should be interesting for you to evaluate in Ecuador or Latin America, because we don't have such information in Europe. You can save a lot of, I would say, add-on, erythropoietin, nutritional aspect, and so on and so on. This is an element which is very important. And particularly if you want to promote the hemodial filtration to go to the healthcare authority, maybe this is a very important point. It's not just saving the life of the patient, but bringing, I would say, so additional element of this element. I think you have several elements to confirm that the efficiency is there. Now, looking on the second question, which is limitation on the blood flow. I agree. If you cannot make blood flow which is more than 200 ml a minute, the idea is not to focus on hemodial filtration. Make the regular hemodialysis, try to fix your vascular access, create a fistula, remove the catheters, do what you can do to improve the fistula or the vascular access. There is no emergency to switch the patient from hemodialysis to hemodial filtration. I think it's better to have good hemodialysis than very poor hemodiafiltration. Because if you are not able to provide a high flow or the optimal flow to make sure that the filters is able to make this filtration, maybe the efficiency is reduced and not increased. So I will focus first on the vascular access to make sure that you get vascular access which is functioning as you expect. Then set hemodialysis with a more efficient one. And then step 3, move to the hemodiafiltration. There is no need to move immediately to hemodiafiltration. You need to set off this element. Now, on the blood flow, very low blood flow, this is the case for Japanese or Asian population. In Asia, they have smaller people, very small or low flow fistula, and they are afraid by the high blood flow that we are developing in Europe or in America. So they said maximum is 200, 250 ml as a blood flow, extracorporeal. But still they develop hemodiafiltration, and they develop pre-dilution. So another option, if your vascular access is not functioning well, if you have some limitation of your patient, you can switch on the machine from post to pre. But this is, from the sustainability, this is not perfect, but you will achieve the efficiency, but certainly not the sustainability that you want to do with a post-dilution.
Muchísimas gracias. Bueno, muchísimas gracias a todos por haber participado de este simposio. Esperamos que surjan ideas, que conviertan en proyectos y que sean proyectos de implementación en sus pacientes. Muchísimas gracias, profesor Canaud. Muchísimas gracias a todos por estar hoy. Disfruten de este congreso.
Muchas gracias.
Nos vemos en la próxima. Muchas gracias, doctor.
Thank you.
Merci.